Welcome everyone, it's Friday at the Canadian Rheumatology Annual Scientific Meeting. I'm Shannon from the Arthritis Patient Advisory Board at Arthritis Research Canada, and with me I have Alexandra Legge, who is an internal resident at Dalhousie and beginning your rheumatology residency this summer.
Yes.
And you're at the meeting presenting a mysterious case.
Yes, that's
and right. A poster, so I would love it for you to tell everybody about that.
Sure. So my mysterious case that I was presenting on Wednesday was a case of a gentleman with a rare small vessel vasculitis called eosinophilic granulomatosis with polyangiitis, or EGPA. And the really interesting and fascinating thing about his case was that he was presenting with symptoms that were much more suggestive and quite typical for a more common condition we see in rheumatology called giant cell arteritis or temporal arteritis. And so I think it was a great case and has a great clinical pearl there, as far as always remembering to be aware of potential mimics of common diseases that we see, and really keeping an open mind and a broad differential diagnosis, particularly when there are aspects of the history or laboratory findings that don't quite fit with what you would maybe expect to see.
Sometimes can that be just like one little piece that doesn't appear to fit the rest of the puzzle that leads you down the other path to investigate further for something else?
Exactly. And I think, to be honest, I think that's something that really actually attracted me to the field of rheumatology, is I think it just requires such clinical acumen to really pay close attention to just tiny aspects of the history or tiny things on a physical examination or on blood work that could really change the clinical picture for you. So I think it's something that's just really fascinating.
Well, I think it drives the point home as well for patients that feel like they're not being heard, that as much as they can feel like they're not being heard, the physician may not be hearing them, but how important it is for them to be heard, even though there might be a bunch of information that's not relevant, that you never know when something relevant might pop out of that.
Absolutely, exactly.
And what's your poster on?
So my poster focuses on some research that I actually conducted during a recent master's degree that I completed at Dalhousie under the supervision of Dr. John Hanley in the Division of Rheumatology there. So this was a project that was looking at using the concept of frailty to create a new prognostic tool for patients with systemic lupus.
Oh, really? And so what are the conclusions on the poster then?
Sure. So we were able to successfully construct the tool, which is something known as a frailty index. And essentially what we found was that frailty index scores early in disease were predictive of future mortality, as well as other important outcomes like organ damage and hospitalizations. That
lupus is a nasty one, right? So many aspects, they all have different, manifestations. Everybody's different, but I do know a little bit about lupus, having a long-term friend that's had it for 25, 30 years. Just how much can be going on with lupus patients. So the research that's being done to fine-tune these diagnostics and these interventions.
Exactly. I think something that really drove us towards doing this type of research was the fact that systemic lupus is just such a heterogeneous disease, and so the presentations and the outcomes are so variable and can be very challenging to predict. And so we really feel that there's a need there for better prognostic tools to help us try and identify patients who are particularly vulnerable to adverse outcomes early in their disease, so that maybe we could, maybe they could benefit from closer monitoring or more aggressive interventions early in their disease course to prevent later negative outcomes.
Well, because early in their disease course might be much later, their diagnosis might be much later in their disease course, just because of the way that lupus is diagnosed during childbearing years in women. So which could be, they could have been experiencing issues for a good majority of their lives, thinking they were just an unwell person, because they have had so many different things that didn't seem to connect. And then when they're finally diagnosed.
Definitely, I mean, you'll often hear that lupus is the disease of 1,000 faces. So it's a disease that sometimes, particularly if someone's not presenting with all of the very typical symptoms, sometimes there is a very long delay in diagnosis and effective therapy. So absolutely.
And the therapies have really changed over the last 30 years. What do you see coming down the pipe for the next 10 or 15 years, or 5 or 10 years, of what your hope is for these patients?
So definitely there has been amazing progress in therapeutics in rheumatology in general. Unfortunately, sort of the success of those therapeutics maybe hasn't been quite so great in systemic lupus as it has been in some other conditions like rheumatoid arthritis or psoriatic arthritis. So I think, my hope is that carrying on in the next 5 to 10 years, that hopefully we will see some of these new therapeutics being applied successfully in systemic lupus and having some new biologic or small molecule therapies that are going to be effective for our patients.
Things are happening so fast, that's not really a big stretch.
No, exactly.
Is it? And so on this year's meeting theme, Building Bridges, what does that say to you? What does that mean to you, building bridges?
Well, I love the theme. I think it's a fantastic theme. And to me, it really speaks to, and it's all about collaboration, which is so important in everything we do, both in patient care and also in research. So I think that it's a great theme, and I think the organizing committee has done a great job at weaving that into all the sessions that we've been attending.
Now, you've spent your residency in a time where patient-centered care has come to the forefront, so it's changed the dynamic a little bit. How have you found going through your residency with that change in attitude, sort of, and change in maybe way medicine's administered, as opposed to how it made old school, I'll say?
Sure. So I definitely agree. I think there has been a huge sort of shift in medicine in general towards providing more patient-centered care. And I personally think that's a tremendously positive thing. And I think there's really a few areas of medicine where you see that playing out any more so than in rheumatology. We do have, for many of our conditions, a number of treatment options now. And so much of our treatment decisions are really driven by patient preference as far as how are symptoms affecting function, how are they affecting quality of life, what side effects are particularly important to a certain individual, what are the fertility considerations that we need to think about for a particular individual. So again, I think that's something that's really attracted me to rheumatology, is that what's right for one patient with a particular condition might not be what's right for the patient that's in the next room over with the same condition.
There's no cookie-cutter solutions.
Yeah, exactly. And I think I enjoy having those conversations with patients and discussing the pros and cons of different treatment options. So I think that's a shift, like I said, that's been tremendously positive, and one that I definitely welcome.
Now, in the environment, are you finding that your mentors are also open to that culture? you know, when they're
Mhm.
working with residents and fellows, et cetera?
Definitely. I think that in particular in the Division of Rheumatology where I train in Halifax, I see my mentors providing patient-centered care to their patients, and that's sort of where I'm getting that mentorship and that role modeling to be able to do the same as I progress in my training.
I think that when you're being trained that way, it's really facilitates the relationship, the ongoing relationship that a rheumatologist has with the patient, and to have that open communication and to not hide anything, you know, from each
Exactly.
other, to be completely open so that you can receive the best treatment and best outcomes. So what do you plan to do? You know, are you going to, would you like to be, for example, after you're done your residency, like part of a hub clinic, you know, a clinic that's all encompassing, that with multidisciplinary for arthritis, or in a private clinic, or do you have a preference, or are you leaning any?
I suppose I haven't made a lot of decisions yet, but I definitely see research being a big part of my career moving forward. So definitely I'd like to be at a center where I can provide patient care, but also have the opportunity to continue with my research endeavors.
And do you have anything next step research, you know, to-do lists?
So as far as next steps, I would say I do plan to continue on doing some additional work with the frailty index that we've been working on. So specifically trying to apply it to some different cohorts of lupus patients to ensure that it is performing well for predicting outcomes in different populations.
Right. So do we have any questions from our audience?
Yes. Do you have any tips about getting into residency and into the field of rheumatology?
Sure. Oh, that's a great question. So I think for me, a really important thing was being exposed to rheumatology early on. So actually my mother has rheumatoid arthritis, so that was something that really drew me to the field initially when I was early in my medical career in medical school. So I think having early exposure to do elective experiences in rheumatology clinics is really important, because I think there are some medical students and residents who miss out on the opportunity to be involved in this field simply because they're never exposed to it, or they're only exposed to it after they've sort of made their commitment or decision to go into another field. So I think it's a really welcoming community of...
They will be appreciated. There is a definitely high appreciation factor.
It's such a welcoming community of physicians and researchers and patients. So I think that really anyone who's interested in rheumatology and enthusiastic about it should just try to get some experience in the field, and I think they'll find that they're welcomed here with open arms.
Yes, very much so. Was there any further questions? Well, thanks again for sitting down with us.
It's my pleasure.
And I wish you all the best in your future research, because we know it's going to help us. So thank you for joining us, and we will see you for our next interview.